Welcome to a deep dive into the very engine room of your body, the cardiovascular and vascular systems. We've got a stack of source material here that pulls back the curtain on how blood moves, what keeps it going, what happens when the system faces challenges, and how we figure out what's actually going on.
Yeah, it's like exploring your most vital, always-on delivery network. It's pretty incredible when you think about it.
Absolutely. And what ties all these different pieces together, from the heart's chambers to the tiniest capillary, is this idea of perfusion, right?
Perfusion, exactly. It's the key concept. It's all about the delivery of life-giving oxygen and nutrients to every single cell in your body. Everything we talk about today really comes back to making sure that delivery happens effectively.
Right. So this deep dive is specifically designed to navigate the sources you've shared with us, looking at how clinicians assess this incredible system, exploring key cardiac conditions, and we're going to put a real focus on heart failure today.
And then we'll shift gears a bit.
Yeah, shifting to common issues with the vessels themselves, the pipes, if you will. So our mission, to guide you through this material, highlight the essential bits of knowledge, show how the heart and the vessels connect.
And zeroing in on what really matters for understanding your overall circulatory health.
Exactly. It's about getting a clear, powerful picture without feeling, completely overwhelmed by every single detail.
It's about seeing the forest and the trees, but knowing which trees are the most important ones to look at. So maybe we should start with the core system itself, built around that crucial idea of perfusion.
Okay, perfusion. It sounds technical, maybe a bit intimidating.
Well, it doesn't have to be. It's really just about getting the blood where it needs to go. Effectively, anyway.
Like ensuring every house on the street gets its mail delivery on time with all the important packages.
Precisely. It's the blood flow through the capillaries, those tiny, tiny vessels where the real exchange happens. Oxygen, nutrients, waste products, swapping between the blood and the tissues. If perfusion isn't adequate, tissues just don't get what they need to survive and function.
So as we talk about the heart and vessels, we should keep asking, is the blood getting where it needs to go?
That's the fundamental question. And the star of the show, the engine driving this whole system, is the heart. The sources describe it almost like a house, a four-chambered house. Can you walk us through those rooms?
Yeah, what are their specific jobs?
Absolutely. It's an amazing, tireless muscle. So deoxygenated blood that's already delivered its oxygen around the body, returns to the right side of the heart. It first enters the right atrium, the upper right chamber.
Okay.
It gets there mainly through two big veins, the superior vena cava, bringing blood from the upper body, and the inferior vena cava from the lower body. Think of the right atrium as like the main receiving bay for used blood.
Okay, so blood from the body collects in the right atrium. Then where?
From the right atrium, it flows down into the right ventricle, the lower right chamber. Now, the right ventricle's main job is to pump this deoxygenated blood over to the lungs so it can pick up fresh oxygen.
Okay.
It pumps this blood away from the heart through the pulmonary artery. Now, this is one of those little quirks you have to remember.
Right. Arteries usually carry oxygenated blood.
Usually, yes. But the pulmonary artery carries deoxygenated blood. The key is the direction. Arteries carry blood away from the heart. That rule still holds.
Got it. Arteries away. Pulmonary artery takes deoxygenated blood to the lungs.
Exactly. So in the lungs, the blood drops off its carbon dioxide, picks up oxygen. Then this fresh oxygenated blood returns to the heart, but this time to the left side. It enters the left atrium, the upper left chamber,
And it gets there through.
the pulmonary veins.
Yeah.
And here's the flip side of that exception. Veins usually carry deoxygenated blood to the heart, but the pulmonary veins carry oxygenated blood from the lungs to the heart.
So exceptions confirm the rule, kind of. Left atrium gets the good stuff back from the lungs. And then into the powerhouse.
The left ventricle, the lower left chamber. This is the main pump for the whole body. It pumps that oxygenated blood away from the heart out into the aorta, which is the body's largest artery.
And the sources really emphasize why the left ventricle wall is so thick, right?
They do. It has the thickest muscular wall because it has to generate way more pressure. It needs to overcome the resistance of the entire systemic circulation, pushing blood from your head all the way down to your toes. The right ventricle, just pumping next door to the lungs, has a much easier job, pressure-wise.
Makes sense. And the heart muscle itself, the myocardium, it needs its own blood supply, too.
Oh, absolutely.
Yeah.
Constantly working muscle like that needs a dedicated fuel line. That's the job of the coronary arteries. They branch off the aorta right at the beginning and feed the heart muscle itself.
And if those get blocked?
That's when you run into big trouble. Blockage there leads to ischemia, lack of blood flow, and potentially infarction, which is muscle death. That's a myocardial infarction, an MI, a heart attack. And obviously that severely impacts the pump's ability to do its job.
Okay, so we have the chambers moving the blood, but to keep it all going in the right direction, we need those valves. The sources call them one-way doors.
That is a great way to think about it.
Yeah.
These 4 valves are absolutely critical. They prevent backflow, ensuring that blood moves forward efficiently through the chambers and out into the vessels with each beat.
Where are these valves located? Can you walk us through them?
Sure. On the right side, you've got the tricuspid valve sitting between the right atrium and the right ventricle. Then the pulmonic valve is between the right ventricle and the pulmonary artery, guarding the exit to the lungs.
Okay, tricuspid, then pulmonic on the right.
Then on the left side, you have the mitral valve, sometimes called the bicuspid valve, between the left atrium and left ventricle. And finally, the aortic valve sits between the powerful left ventricle and the aorta, controlling blood flow out to the body.
You know, the source mentioned a mnemonic. Try pulling my aorta. That actually sticks. Tricuspid, pulmonic, mitral, aortic. The order blood flows through.
It's handy, isn't it?
Yeah.
So we have this 4-chambered house with its one-way doors. How does it actually perform the pumping action? That brings us to the cardiac cycle, which is divided into 2 main phases, systole and diastole.
Systole is the squeeze, right? The contraction.
Yes, systole is the contraction phase, specifically when the ventricles contract. They squeeze down, forcing blood out. Now, for this to happen, the exit doors, the aortic and pulmonic valves have to swing open.
Okay.
And at the very same time, to stop blood from squirting back up into the atria, the entry doors, the mitral and tricuspid valves, have to snap shut.
And that's the first heart sound, the lub. Those entry valves closing.
Exactly. S1, the lub, is the sound of the mitral and tricuspid valves closing at the beginning of systole.
Okay. And diastole.
Diastole is the relaxation phase. The heart muscle relaxes and the ventricles fill up with blood flowing down from the atria. So during diastole, the entry valves, mitral and tricuspid, are open, letting the blood flow in.
And the exit valves must be closed then.
Right. The aortic and pulmonic valves are closed during diastole to prevent the blood that was just pumped out into the aorta and pulmonary artery from falling back into the relaxing ventricles.
And that closing makes the dub sound, S2.
That's it. The dub S2 is the sound of the aortic and pulmonic valves closing at the end of systole, marking the beginning of diastole. So lub dub, squeeze and fill, squeeze and fill.
Okay, so how do we measure how well this cycle is actually moving blood? The sources talk about stroke volume and cardiac output.
Yeah, these are key metrics. Stroke volume, or SV, is the amount of blood ejected by one ventricle. Usually we focus on the left with each single beat. Think of it as the volume pushed out in one successful squeeze.
And what's a typical amount?
It's usually around 60 to 100 milliliters per beat in a healthy adult at rest.
Okay, 60 to 100 milliliter per beat. That's stroke volume. And cardiac output.
Cardiac output, or CO, is the total volume of blood the heart pumps per minute. This is really the critical measure of the heart's overall performance in meeting the body's demands at any given time.
How do you figure that out?
It's a simple formula, actually. Cardiac output equals heart rate, your pulse in beats per minute, multiplied by stroke volume, the ml per beat. CO is HR, A says V.
Makes sense. Pump faster or pump more with each beat, and your output goes up.
Exactly. The normal range for cardiac output at rest is typically somewhere between 4 and 8 liters per minute. This number tells you the raw pumping power over time.
And coordinating all this squeezing and filling, making sure the chambers contract in the right sequence, that's the job of the heart's own electrical system.
It's fascinating, really. The heart has its own built-in electrical conduction pathway. It doesn't need the brain to tell it to beat, although the brain can tell it to beat faster or slower.
So where does the spark start?
It starts at the sinoatrial node, the SA node, which is located up in the wall of the right atrium. This is the heart's natural pacemaker. It spontaneously generates electrical impulses at a regular rate, initiating each heartbeat.
Okay, SA node fires first.
Yes. That electrical signal then spreads across both atria, like ripples in a pond, causing them to contract and push blood down into the ventricles. The signal then converges at the atrioventricular node, the AV node, which sits low down between the atria and ventricles.
And the AV node does something important.
It introduces a very slight delay. It holds onto the signal for just a fraction of a second.
Why the pause seems counterintuitive.
It's crucial. That pause allows time for the atria to fully contract and empty all their blood into the ventricles before the ventricles get the signal to squeeze. You want the pumps full before you turn them on, right?
Ah, okay. Good timing mechanism.
Exactly. After that brief pause, The signal travels very quickly down specialized fibers. First the bundle of His, then it splits into right and left bundle branches, and finally out through the Purkinje fibers, which spread throughout the walls of the ventricles.
And that rapid spread causes?
A coordinated, powerful contraction of both ventricles, pushing blood out into the pulmonary artery and the aorta almost simultaneously. So the sequence is SA node fires atrial contraction, AV node pauses, A signal races down. Bundle of His Purkinje fibers, aventricular contraction. That's the rhythm.
Amazing internal choreography. Okay, we've covered the pump and its controls. Now let's talk about the network it supplies, the vascular system, the pipes. The sources call this the peripheral vascular system, meaning everything outside the heart.
Right. And the main players are arteries and veins. We already touched on the pulmonary exceptions.
Yeah, but what are the general rules? How are arteries and veins typically different?
Generally, arteries carry oxygenated blood away from the heart to the rest of the body. They're built for high pressure because they receive the direct force from the left ventricle. So they have thick, muscular, and importantly, elastic walls. They stretch with each pulse and then recoil, which helps keep blood flowing smoothly even during diastole.
Built tough for the pressure wave. And veins.
Veins generally carry deoxygenated blood back to the heart from the tissues. They're a lower pressure system. Their walls are thinner and less muscular than arteries, but they can expand quite a bit to hold blood volume. They're capacitance vessels.
And they have valves too.
Critically important, yes. Especially in the limbs, veins have one-way valves inside them. Since the pressure is low and blood often has to travel against gravity, these valves prevent blood from flowing backward and pooling down in your legs and feet.
So valves are key in both the heart and the veins for direction.
Absolutely essential for efficient circulation, especially venous return. And the place where the actual delivery work happens, that perfusion we keep mentioning, is in the smallest vessels, the capillaries.
Microscopic connections between arteries and veins.
Exactly. They form vast networks that connect the smallest arteries, arterioles, to the smallest veins, venules. This is where the magic happens.
The loading docks, you said.
The loading dock, the exchange counter, yeah. Blood flow slows way down in the capillaries. Think of it like going from a highway onto quiet neighborhood streets. This slow transit time is crucial.
Why slow?
It allows enough time for diffusion. Oxygen and nutrients move out of the blood and into the surrounding tissues, while carbon dioxide and other waste products move from the tissues back into the blood to be carried away for disposal. Fluid also shifts back and forth based on pressures, delivering what's needed and picking up waste.
Okay, so arteries. Fast delivery under pressure. Capillaries. Slow, detailed exchange. Veins. Low pressure collection and return. But how does blood get back uphill to the heart from, say, your feet against gravity in those low-pressure veins? The sources mentioned a few mechanisms for venous return.
It's not just passive flow, waiting for the heart to suck it back. The body has some clever tricks. One major one is the skeletal muscle pump. When you walk, run, or even just tense your leg muscles, they contract.
Yeah.
When those muscles squeeze the veins running through or between them, it pushes the blood upward. Since the valves only allow one-way flow towards the heart, this muscular compression acts like a pump, milking the blood back up.
So just moving around helps your circulation fight gravity. That's practical.
Very practical. Immobility is a big reason blood can pool in the legs. Another mechanism is the respiratory pump. When you breathe in, your diaphragm contracts and moves downward.
Okay.
This increases the pressure in your abdominal cavity and decreases the pressure in your chest cavity, thorax.
Well,
This pressure difference creates a gradient that helps pull venous blood from your abdomen up into the lower pressure chest and towards the heart.
wow, so just breathing normally helps pull blood back.
It does. And finally, there's sympathetic tone. The sympathetic nervous system maintains a sort of baseline level of constriction in the veins. This slight tightening helps maintain some pressure within the venous system and prevents too much blood from just pooling idly in the periphery. It encourages return.
So it's an active return system using muscles, breathing, and nerve tone, not just gravity working against it.
It's a much more dynamic process than people often realize. So, pump, high pressure delivery, slow exchange, low pressure collection, aided return. That's the whole loop.
An incredibly complex, integrated system, constantly adjusting. Okay, to understand how well it's all performing, we need some key numbers. The sources emphasize that beyond just the systolic and diastolic blood pressure readings we're familiar with, mean arterial pressure, or MAP, is really important.
Yes, MAP is considered a really crucial indicator.
Why MAP? What makes it maybe even more informative than just the top and bottom BP number?
Well, Systolic pressure tells you the peak pressure during contraction, and diastolic tells you the lowest pressure during relaxation. But MAP gives you the average pressure that's actually driving blood flow into your tissues throughout the entire cardiac cycle. It's a better reflection of the actual perfusion pressure, the force pushing blood into those capillary beds.
Okay, so it's about the average driving force for tissue perfusion. Is there a critical level we need?
The sources generally state that a MAP between 60 and 70 millimeters of mercury, millimeter Hg, is the minimum needed to ensure adequate blood flow, adequate perfusion to vital organs like the brain, kidneys, and heart itself. If MAP consistently drops below 60, those organs are at risk.
And what's considered a normal MAP range?
Usually somewhere between 70 and 100 millimeter Hg is considered normal, and the way it's calculated reflects the time spent in each phase.
Right, you mentioned the formula.
Yeah, it's MAP 2 diastolic pressure plus systolic pressure 3. You see, diastolic pressure is weighted more heavily multiplied by 2 because the heart actually spends about 2/3 of the cardiac cycle in diastole, the filling phase.
Ah, okay. That makes sense, why it's weighted. So MAP gives a better sense of continuous perfusion pressure. And overall, blood pressure is tightly regulated.
Oh, incredibly tightly. It involves a constant interplay between the autonomic nervous system adjusting heart rate and how constricted or relaxed your blood vessels are, the kidneys, which manage your body's fluid volume and release hormones like renin.
Part of that RAS system we'll get to later.
Exactly. And other endocrine systems releasing various hormones. Plus, you have sensors called baroreceptors located in your major arteries. They constantly monitor pressure changes and send signals to your brainstem, which then makes immediate adjustments. Like when you stand up quickly, baroreceptors detect the potential drop in pressure and trigger responses to keep blood flowing to your brain.
A very sophisticated control system. Okay, let's loop back to the heart muscle itself, the pump mechanics. Two concepts kept coming up in the sources as really key for understanding how the heart functions and, importantly, how it can fail: preload and afterload.
Yes, these are fundamental to understanding the heart's workload and efficiency. Preload is essentially the amount of stretch on the heart muscle fibers at the very end of diastole, just before the ventricle contracts.
So it's related to the volume of blood filling the ventricle.
Exactly. It's determined by the volume of blood in the ventricle right before the squeeze, what's called the end diastolic volume. More volume equals more stretch, up to a certain point. Think of stretching a rubber band.
The more you stretch it, within limits, the harder it snaps back.
Precisely. That's related to Starling's law of the heart. Increased preload, or stretch, generally leads to a stronger contraction, again, up to an optimal point. Beyond that, overstretching actually weakens the contraction.
Okay, so preload is the volume load, the stretch before the squeeze. What's afterload?
Afterload is the resistance or pressure that the ventricle has to overcome to eject blood during systole. It's the load the heart muscle is pushing against to get the blood out into the circulation.
So for the left ventricle, that resistance comes mainly
from the pressure in the aorta and the overall resistance in the systemic arteries. Essentially, your systolic blood pressure is a clinical measure reflecting the afterload the left ventricle is working against.
So if someone has high blood pressure or their arteries are stiff and narrow due to atherosclerosis, their afterload is higher.
Exactly. The heart has to work much harder to generate enough pressure to force open that aortic valve and push blood out against that high resistance. Over time, constantly working against high afterload puts a huge strain on the heart muscle, leading to thickening and eventually, potentially, failure.
Got it. Preload increases filling volume stretch. Afterload resistance to ejection. Crucial concepts. Now, how do clinicians actually assess how well this whole pump and pipe system is working? The sources outlined a focused cardiovascular assessment.
Assessment really involves gathering clues from multiple angles. It starts with just looking inspection. You look for visual signs. Skin color is important. Is there cyanosis, a bluish tint, suggesting poor oxygenation? Is there pallor, unusual paleness, maybe indicating poor flow or anemia?
What else do you look for?
Edema swelling, especially in the lower legs, ankles, feet, or even the abdomen or sacral area if someone's bedbound. This points towards fluid accumulation, often seen in heart failure or venous problems. And you look at the neck veins for jugular venous distension, or JVD. Bulging neck veins suggest increased pressure on the right side of the heart, blood backing up.
So just observing can yield a lot of information. Then palpation feeling.
Right. Palpation involves using touch. You feel for pulses at different points: wrist, radial, neck, carotid, foot, pedal pulses. You're checking the rate, the rhythm, and crucially, the strength or quality of the pulse. A weak, thready, or absent pulse can indicate poor arterial flow to that limb.
What else do you feel for?
Skin temperature. Are the hands and feet warm, suggesting good peripheral circulation, or are they cool or cold? You might also feel for capillary refill pressing on a nail bed and seeing how quickly the pink color returns. Slow refill suggests poor perfusion.
Okay, looking and feeling. Then auscultation listening.
Listening with a stethoscope is key. Primarily, listening to the heart sounds. You listen for that normal S1 and S2, the lub-dub, but you also listen carefully for any extra sounds. An S3 sound can indicate volume overload, like fluid sloshing into a ventricle. An S4 can suggest a stiff, non-compliant ventricle struggling to fill.
And murmurs.
Murmurs are sounds created by turbulent blood flow, often caused by faulty heart valves, either narrowed stenotic valves that blood struggles to get through, or leaky regurgitant valves that allow backflow. You also listen for pericardial friction rubs, which can indicate inflammation around the heart. And listening directly over the apex of the heart gives you the apical pulse, the most accurate measure of heart rate and rhythm.
And you can't forget basic vital signs.
Absolutely fundamental. Tracking blood pressure trends over time is vital. You look for things like orthostatic hypotension, a significant drop in blood pressure when the person stands up from sitting or lying down, which can indicate dehydration or medication side effects or autonomic issues. You also look at the pulse pressure, the difference between systolic and diastolic. A narrow pulse pressure might suggest low stroke volume.
So the physical exam provides a wealth of clues, but then there are diagnostic tests for a deeper look.
Yes, technology gives us amazing insights. Electrocardiogram, ECG or EKG, is fundamental. It records the heart's electrical activity, shows the rate, the rhythm, is it regular, irregular, are there arrhythmias, and it can show evidence of ischemia, reduced blood flow causing electrical changes, or infarction, heart muscle damage causing specific patterns.
So ECG is the electrical picture. What about the structure and function, the plumbing itself?
For that, the echocardiogram, or echo, is invaluable. It uses ultrasound waves to create moving pictures of the heart. You can see the chambers, watch the walls contract, see how well the valves are opening and closing.
And it measures that ejection fraction you mentioned.
Yes, critically. The echo calculates the ejection fraction, or EF, the percentage of blood the left ventricle pumps out with each beat. Remember, normal is typically 55% to 70%. A low EF is a key indicator of systolic heart failure, meaning the squeeze is weak. An echo gives you the best look at the heart's overall pumping strength and valve function.
Okay, echo for structure and squeeze strength. What about stress testing?
Stress testing sees how the heart handles increased demand. The person exercises on a treadmill or bike, or sometimes gets medication to simulate exercise effects, while their ECG and vital signs are monitored. It helps uncover blockages in the coronary arteries that might only cause problems when the heart is working hard and needs more oxygen.
Makes sense. And cardiac catheterization sounds like a more invasive but powerful tool.
It is. It's both diagnostic and often therapeutic. A thin tube, a catheter, is inserted into an artery or vein, usually in the wrist or groin, and threaded up to the heart. Doctors can measure pressures inside the heart chambers, inject contrast dye to visualize the coronary arteries and angiography, and look for blockages, check valve function, and even perform interventions like angioplasty, ballooning open a blockage, or placing a stent to keep an artery open.
When would they typically use a cath?
The sources list several reasons: investigating chest pain, angina, evaluating arrhythmias, assessing heart valve disease severity, diagnosing and treating coronary artery disease, CAD, looking at congenital heart defects, assessing the hemodynamics in heart failure, and even looking at problems in very small coronary vessels.
And there's important care needed before and after.
Definitely. Pre-procedure includes checks like kidney function because of the contrast dye, allergies, and stopping certain meds like blood thinners. Post-procedure involves monitoring the insertion site for bleeding or hematoma, checking pulses downstream, keeping the limb straight for a period, and pushing fluids to help flush out the contrast dye.
Okay. And finally, blood tests provide chemical clues about the heart.
Yes, certain biomarkers are very helpful. Troponin is a key one. It's a protein found in heart muscle cells. When heart muscle is damaged, like during a heart attack, troponin leaks out into the bloodstream. Elevated troponin levels are a very sensitive and specific indicator of myocardial injury or infarction.
So high troponin, heart muscle damage.
Pretty much. Then there's BNP, B-type natriuretic peptide. We mentioned this earlier. It's a hormone released by the heart's ventricles when they are stretched, typically due to increased pressure and volume overload, as seen in heart failure.
So BNP levels correlate with how stretched the heart is by fluid.
Exactly. The higher the BNP level, the more the ventricles are stretched, indicating more significant fluid overload and usually more severe heart failure. while specific numbers are given in the sources like below 100 pgml, making HF unlikely, 100, 300 suggesting HF is present, and levels over 300, 600, 900 indicating mild, moderate, or severe HF respectively, the trend is often most important. Watching BNP levels go down with treatment suggests the fluid overload is improving.
That's useful for tracking progress. Any other key blood tests?
Well, a serum lipid panel measures cholesterol levels, total LDL, HDL, triglycerides, which are major risk factors for atherosclerosis. And C-reactive protein, or CRP, is a marker of inflammation in the body, which also plays a role in cardiovascular disease.
Okay, we've built a solid foundation. The system, how we measure it, how we assess it. Now let's use all that to really dig into one of the major problems highlighted in the sources. Heart failure, HF.
Right. HF is a really important condition to understand because it perfectly illustrates that concept of inadequate perfusion, this time caused by the pump itself failing. And importantly, it's not that the heart suddenly stops.
Like in cardiac arrest.
Right. It's that the heart muscle becomes unable to pump blood effectively enough to meet the body's metabolic demands. It's essentially pump failure. And a key point from the sources is the role of the body's own responses.
The compensatory mechanisms.
Exactly. The body tries to compensate for the low output, but these mechanisms, while helpful maybe in the very short term, actually end up damaging the heart further and making the failure worse over time. It's a vicious cycle.
And HF can show up differently. Acute versus chronic?
Yes, it can develop suddenly, perhaps after a large heart attack, acute HF, or it can develop gradually over months or years, chronic HF. Both can be life-threatening and significantly impact quality of life by impairing that essential perfusion.
The type of HF often depends on which side of the heart is struggling most, right? Left-sided seems most common.
It is. Left-sided heart failure usually happens first and is often the cause of right-sided failure later on. In left-sided HF, the main pumping chamber, the left ventricle, can't pump blood effectively out to the body via the aorta.
And what usually causes that?
The most common culprits are long-standing, uncontrolled hypertension, high blood pressure, which increases afterload for years, and coronary artery disease, CAD, which damages the heart muscle through things like heart attacks. Valvular disease affecting the left side valves is another major cause.
So if the left ventricle isn't pumping blood forward well, where does the blood go?
It backs up. If it can't get out efficiently, pressure builds in the left ventricle, then that pressure backs up into the left atrium above it. From the left atrium, the pressure and fluid back up into the pulmonary veins and ultimately into the lungs themselves.
Ah, so that's the congestion. Fluid in the lungs.
Exactly. This pulmonary congestion is the hallmark of left-sided failure, hence the older term congestive heart failure, CHF. So you get two major problems. Decreased tissue perfusion systemically because not enough oxygenated blood is getting out to the body, and that fluid back up into the lungs causing respiratory symptoms.
And the sources break down left-sided failure into two subtypes based on how the ventricle is failing.
Yes, this is an important distinction. First, there's systolic heart failure, which is now more precisely called heart failure with reduced ejection fraction, or HFrEF, pronounced HEF-ref.
Reduced EF, so the squeeze is weak.
Exactly. In HFrEF, the heart muscle itself is often thin, weak, or damaged. It simply can't contract forcefully enough during systole to eject a normal amount of blood. The ejection fraction is significantly lower than normal, typically below 40% or even lower. It's primarily a problem with the heart's contractility, its squeezing power.
Okay, a weak squeeze leads to reduced output. What's the other type? Diastolic HF?
Right. Diastolic heart failure is now called heart failure with preserved ejection fraction, or HFpEF, HFpEF. Here, the problem isn't necessarily the squeeze itself. The EF might be normal or close to normal, above 50%.
So if the squeeze is okay, what's the problem?
The problem is filling. In HFpEF, the heart muscle, particularly the left ventricle wall, has often become thick, stiff, and non-compliant. Think back to that hypertrophy we mentioned. Because it's stiff, the ventricle can't relax properly during diastole to allow adequate filling.
So it doesn't fill up enough before it squeezes?
Precisely. It starts with less blood in the tank. So even if it ejects a normal percentage, preserved EF, the actual stroke volume, the amount pumped out, might be too low to meet the body's needs, especially during activity. This HFpEF is increasingly common, especially in older adults, often linked to chronic hypertension that wasn't caught or treated effectively over many years.
So HFrEF is a squeeze problem, low EF. HFpEF is a filling problem, normal EF but stiff heart. Very different mechanisms leading to similar overall pump failure. What about right-sided HF?
Right-sided HF happens when the right ventricle can't pump blood effectively out into the pulmonary artery towards the lungs. When the RV struggles to empty, blood backs up behind it.
And behind the right ventricle is.
The right atrium and then the entire systemic venous system, the veins bringing blood back from the body. This backup increases pressure in the veins, forcing fluid out into the body tissues.
So that's where the peripheral edema comes from. Swelling in the legs, ankles, abdomen.
Exactly. That systemic venous congestion is the hallmark of right-sided failure. Now, the most common cause of right-sided HF is actually left-sided HF.
How does that work?
Remember how left-sided failure causes fluid backup into the lungs? That increases pressure in the pulmonary artery. The right ventricle has to pump against this higher pressure, this increased afterload. Over time, this strains the RV, causing it to weaken and eventually fail too.
So the left side fails, backs up into the lungs, makes it harder for the right side to pump, and then the right side fails.
That's a very common progression. However, right-sided failure can also happen independently, usually due to lung problems that increase pulmonary pressure directly, like severe COPD, pulmonary fibrosis, pulmonary hypertension from other causes, or even a large pulmonary embolism or acute respiratory distress syndrome, ARDS. A heart attack affecting the right ventricle could also cause it.
Okay, so left-sided failure, lung congestion. Right-sided failure, systemic body swelling. Useful distinction. The sources also mention ways to classify or stage HF.
Yes, there are systems like the American College of Cardiology American Heart Association, ACC-AHA stages, which go from stage A, high risk but no disease yet, to stage D, refractory end-stage HF. There's also the New York Heart Association, NYHA, functional classification, class 1 to IV, which focuses more on how symptoms limit physical activity. They basically help categorize severity and guide treatment intensity.
Let's dive back into those compensatory mechanisms. You said the body tries to help but ends up hurting. Can we unpack that a bit more? How exactly does that happen?
It's really central to understanding chronic HF. When the heart's output drops and tissues sense they aren't getting enough oxygen, hypoxia, alarm bells go off. The body's most immediate response is to activate the sympathetic nervous system, SNS, the fight-or-flight system.
Adrenaline rush.
Basically, yes. It releases catecholamines like adrenaline and noradrenaline. These do a few things. First, they increase the heart rate. The body thinks, if each pump is weak, let's pump faster. Second, they increase contractility, trying to make the squeeze stronger. Third, they cause vasoconstriction, tightening of the arteries, trying to raise blood pressure and shunt blood toward the core organs.
Sounds like a reasonable emergency response.
For short-term crisis, maybe. But in chronic HF, it backfires badly. A persistently fast heart rate actually reduces the time the ventricles have to fill between beats, diastole, which can decrease stroke volume, especially in diastolic HF. Plus, a faster, stronger beat uses much more oxygen, starving an already struggling heart muscle.
And the vasoconstriction.
That increases afterload. Remember, afterload is the resistance the heart pumps against. Making the arteries tighter makes it even harder for the failing left ventricle to push blood out. So the SNS response increases the heart's workload and oxygen demand while potentially reducing its output. It's counterproductive long-term.
Okay, so the immediate nerve response makes the heart work harder, but less efficiently. What else kicks in?
The renin-angiotensin-aldosterone system, or RAAS. When the kidneys sense reduced blood flow because of the low cardiac output, they release an enzyme called renin. Renin starts a cascade that ultimately produces a powerful substance called angiotensin II.
And angiotensin II does what?
Two main bad things in HF. First, it's a very potent vasoconstrictor, even more so than the SNS effects. So it jacks up afterload even further, really straining the left ventricle. Second, angiotensin II stimulates the adrenal glands to release another hormone called aldosterone.
Aldosterone, that affects salt and water.
Exactly. Aldosterone tells the kidneys to hold on to sodium, and where sodium goes, water follows. So the body retains fluid, increasing the overall blood volume.
Trying to boost pressure by increasing volume.
That's the misguided idea. This increased volume increases preload, more blood returning to the heart, stretching it more. Again, initially Starling's law might suggest this helps, but in a failing heart, that extra volume just overstretches the weakened muscle fibers, making contractions less effective and increasing the pressure inside the heart chambers. This fluid overload is what directly causes the pulmonary congestion in left HF and the peripheral edema in right HF.
So RAAS increases resistance and volume overload. A double whammy.
A major double whammy.
Ah.
And it gets worse. Angiotensin II and aldosterone also contribute directly to harmful structural changes in the heart muscle over time, called ventricular remodeling. The heart muscle cells can enlarge, die off, and be replaced by fibrous tissue, making the heart stiffer and even less efficient.
Wow. So the body's attempt to maintain pressure and volume actively damages the heart muscle and makes the fluid situation worse.
That's the tragic irony of HF compensation. Other things happen too. Pro-inflammatory cytokines are released from injured heart cells, contributing to remodeling. The heart muscle itself undergoes hypertrophy, thickening initially to try and cope, but eventually becoming too stiff, especially impairing diastolic filling, HFpEF. Vasopressin, antidiuretic hormone, might also be released, causing more fluid retention.
And BNP, where does that fit in? Is it trying to help?
BNP is actually one of the body's counter-regulatory responses. When the ventricles get stretched by all that excess volume and pressure, they release BNP. BNP tries to counteract the bad effects it promotes vasodilation, relaxing blood vessels, and tells the kidneys to excrete sodium and water, diuresis.
So it's the body's natural diuretic and vasodilator.
In a way, yes. It's trying to fight back against the SNS and RAAS activation. The problem is, in significant heart failure, the effects of the SNS and RAAS are just too powerful. The BNP response isn't enough to overcome them. But the fact that the body releases more BNP when it's overloaded makes it such a useful biomarker for us to measure.
It's like a cry for help from the stretched heart. Okay, so the net effect of all these compensatory mechanisms is a heart that's working way too hard, demanding too much oxygen, getting structurally damaged, and drowning in fluid.
That's a pretty accurate summary of the pathophysiology of progressive heart failure. And eventually, the heart just can't keep up, and symptoms worsen.
We know the main causes are often HTN and MI. What other risk factors did the sources highlight? There was Box, right?
Yes, Box 29.1 laid out quite a few. Besides hypertension and previous heart attack, structural heart changes are big, particularly valvular dysfunction, like narrowed, stenotic, or leaky valves that force the heart to work harder. Other causes include infections or inflammation affecting the heart, myocarditis, endocarditis, diseases of the heart muscle itself, cardiomyopathies, congenital heart defects people are born with.
What about other conditions?
Uncontrolled diabetes mellitus is a major risk factor, often contributing to coronary artery disease. Dysrhythmias, like atrial fibrillation, can impair filling and pumping efficiency. Having a family history increases risk. Certain conditions that make the heart work overtime, like severe anemia or hyperthyroidism, hyperkinetic conditions, can contribute. Obesity puts a strain on the heart. Severe lung disease, as we discussed, can lead to right-sided HF. Sleep apnea is increasingly recognized as a significant risk factor. And lifestyle factors like smoking or tobacco use and substance misuse, alcohol, cocaine, are definitely on the list.
It's a wide range of things that can stress or damage the heart over time, and it's particularly common in older adults.
Hugely common. HF is the leading cause for hospital admission for people over 65. And it's important to remember, as the sources point out, that older adults often take other medications. Things like NSAIDs, common over-the-counter pain relievers like ibuprofen or naproxen, can be problematic.
How's that?
NSAIDs can cause the body to retain sodium and water, which directly worsens fluid overload in someone with HF. They can also counteract the effects of some diuretics and blood pressure medications and potentially increase risk of kidney injury, especially when combined with ACE inhibitors or ARBs. So careful medication review is crucial in older adults with HF.
Good point. So, given this complex condition with its vicious cycles, what are the main goals when treating heart failure? How do we intervene?
The primary goals are really aimed at breaking that cycle and improving the heart's efficiency. This means trying to 1. Decrease afterload, making it easier for the heart to pump blood out. 2. Decrease preload, reducing the volume overload and congestion. And 3. Sometimes increase contractility, improving the strength of the squeeze, especially in HFrEF.
And how are those goals achieved in practice?
It's usually a combination approach. Nutrition therapy is fundamental. Since fluid overload is such a big issue, managing sodium and water intake is key. This almost always means a low-sodium diet, typically restricting intake to 2 grams per day or sometimes less, because sodium makes the body retain water.
And restricting fluids directly.
Often, yes. Fluid restrictions, maybe limiting intake to 1.5 or 2 liters per day, might be necessary, especially if sodium levels are low or fluid overload is severe. This helps reduce the total volume the heart has to pump.
Okay, diet is foundational. Then medications seem targeted at those goals and the bad compensatory mechanisms.
Exactly. Medications are a cornerstone of HF management. To tackle preload, fluid overload, diuretics are essential. They help the kidneys get rid of excess sodium and water. Loop diuretics like furosemide, Lasix, torsemide, Demodex, or bumetanide, Gumex, are powerful and commonly used, especially for significant fluid removal. Thiazide diuretics, like hydrochlorothiazide, HCTC, are less potent, but might be used in milder fluid overload or added to loop diuretics in resistant cases. With both loop and thiazide diuretics, you have to watch potassium levels closely as they can cause potassium loss, hypokalemia.
And potassium-sparing ones.
Yes, drugs like spironolactone, aldactone, are potassium-sparing diuretics. They're weaker diuretics, but are often used in HF, not just for fluid, but because they also block aldosterone, which, remember, contributes to remodeling and sodium retention. So they have additional benefits beyond just getting rid of water.
Okay, diuretics handle the volume preload. What about reducing afterload, that resistance the heart pumps against?
That's where vasodilators come in. Drugs that relax the arteries reduce systemic vascular resistance, lowering blood pressure and making it easier for the left ventricle to eject blood. The main classes here are ACE inhibitors and ARBs.
ACE inhibitors, like lisinopril.
Yes, lisinopril, enalapril, captopril, and pramipral. They block the renin-angiotensin-aldosterone system, RAAS, by inhibiting the enzyme that converts angiotensin I to angiotensin II. This leads to vasodilation, lower aldosterone levels, and reduced afterload and preload. They're often considered first-line therapy, especially in HFrEF, as they've been shown to improve survival.
What are the downsides?
They can cause hypotension, low blood pressure, especially initially. A persistent dry cough is a common side effect that makes some people stop taking them. They can also affect kidney function or cause high potassium levels, hyperkalemia, so monitoring is needed.
And if someone can't tolerate the cough?
Then angiotensin receptor blockers, or ARBs, the sartan drugs like losartan, valsartan, irbesartan are often used. They work slightly differently by blocking angiotensin II from binding to its receptors, but the end result is similar. Vasodilation, reduced aldosterone effects, lower afterload. They generally don't cause the cough associated with ACE inhibitors, but have similar risks of hypotension, kidney issues, and hyperkalemia.
The sources also mentioned ARNIs, like Entresto.
Yes, RNAs, angiotensin receptor neprilysin inhibitors, like sacubitril valsartan, or a newer class, they combine an ARB, valsartan, with a drug that inhibits neprilysin. Neprilysin is an enzyme that breaks down beneficial peptides like BNP. By inhibiting it, ARNAs increase levels of these helpful peptides, promoting more vasodilation and sodium excretion while also blocking the negative RAAS effects via the ARB component. They've shown significant benefit over ACE inhibitors in some HFrEF patients, but also require careful monitoring for hypotension, kidney function, and potassium.
Okay, so ACEs, ARBs, RNAs primarily reduce afterload. What about beta blockers? They seem common too.
Beta blockers, the olol drugs like metoprolol, carvedilol, bisoprolol, are also a cornerstone of HFrEF therapy, even though it might seem counterintuitive to slow down a weak heart.
How do they help then?
They block the effects of adrenaline and noradrenaline, those SNS catecholamines, on the heart. This slows the heart rate, giving the ventricle more time to fill, which can actually improve stroke volume in the long run. It also reduces the heart's oxygen demand and workload. Importantly, they also help prevent arrhythmias and have been shown to reverse some of that harmful ventricular remodeling over time and improve survival significantly. They need to be started at low doses and increased slowly, especially in acute HF.
So they protect the heart from the chronic stress of SNS overactivation. We've covered preload and afterload reduction. What about directly boosting the squeeze, increasing contractility?
Those are the inotropic drugs. Digoxin is the classic oral inotrope. It works by increasing calcium levels within the heart muscle cells, which strengthens the force of contraction. It can help improve symptoms and reduce hospitalizations, particularly in HFrEF, but it hasn't been shown to improve survival like ATSARBs or beta blockers.
And it needs careful monitoring.
Very careful. The therapeutic window is narrow, meaning the difference between a helpful dose and a toxic dose is small. Low potassium levels significantly increase the risk of digoxin toxicity, which can cause dangerous arrhythmias, nausea, vomiting, and visual disturbances. Regular monitoring of digoxin levels and potassium is essential. There's an antidote called Digibind, digoxin immune fab, for severe toxicity. In the hospital setting, IV inotropes like dobutamine or milrinone might be used for short-term support in severe acute HF, but long-term use is associated with increased mortality.
It's clearly a complex medication regimen, often involving multiple drugs targeting different pathways, and recognizing when things are going acutely wrong seems critical for patient safety.
Absolutely. Clinical judgment and prioritizing interventions are key. Nurses and other clinicians need to be vigilant for signs of rapid worsening. Pulmonary edema is a major emergency in left-sided HF.
Remind us of the signs.
Sudden, severe shortness of breath, often feeling like drowning. Extreme anxiety, gasping for air. Coughing up pink, frothy sputum is a classic ominous sign, sitting bolt upright to breathe. Auscultation reveals crackles, often throughout both lung fields, sometimes wheezing. The patient might be sweaty, cool, pale, or cyanotic.
What's the immediate action?
This requires rapid intervention. Sit the patient upright, apply high-flow oxygen, establish IV access quickly, administer potent IV loop diuretics like furosemide to pull off fluid fast. Sometimes vasodilators like IV nitroglycerin are used to reduce preload and afterload quickly. Morphine might be used cautiously for anxiety and vasodilation. Continuous monitoring of oxygen saturation, heart rhythm, and vital signs is crucial, and notifying the physician immediately is paramount.
And the other emergency mentioned was cardiac tamponade.
Yes, this is less common but life-threatening.
Yep.
It happens when fluid, blood or inflammatory fluid, accumulates rapidly in the pericardial sac surrounding the heart. This fluid compresses the heart, preventing it from filling properly during diastole.
What are the signs of tamponade?
The classic signs are called Beck's triad: hypotension, low blood pressure because the heart can't fill and pump effectively, muffled or distant heart sounds because the fluid barrier dampens the sound, and marked jugular venous distension, JVD, because blood can't get into the compressed right atrium easily. The patient may also be tachycardic, fast heart rate trying to compensate, and show signs of shock. This requires emergency drainage of the fluid via pericardiocentesis.
Recognizing these emergencies requires sharp assessment skills. And once a patient is stabilized, getting them home safely and keeping them stable seems like a huge challenge.
It really is. Care coordination and transition management are incredibly important in HF because readmission rates are notoriously high. Effective discharge planning is key.
What does that involve?
Making sure follow-up appointments are scheduled with primary care and cardiology. Arranging home health nursing visits if needed, especially early after discharge, for monitoring and reinforcement of teaching. Meticulous medication reconciliation, ensuring the patient understands their current medication list, doses, timing, purpose, and side effects.
And education seems crucial.
Vital. Patients and their families need clear, understandable education on several key areas: their low-sodium diet and any fluid restrictions, how to monitor their weight daily, a sudden gain often signals fluid retention, recognizing worsening symptoms like increased shortness of breath, swelling, fatigue, weight gain, and knowing exactly when and who to call for help versus when to seek emergency care. Good communication between hospital staff, primary care providers, cardiologists, and home care is essential for a smooth transition.
And we have to circle back to health equity considerations here. How do those play out specifically in HF management?
They play a huge role. Medication affordability is a massive barrier for many patients facing multiple, often expensive prescriptions. Health literacy impacts the ability to follow complex regimens. Instructions need to be simplified, use teach-back methods, maybe visual aids. Cultural factors heavily influence dietary habits. Simply handing someone a generic low-sodium list might be useless if it doesn't align with their cultural foods. We need culturally competent approaches to develop realistic, acceptable meal plans.
What about other social determinants?
Things like income, education level, access to transportation for appointments, or grocery shopping for healthy food, living in a food desert without access to fresh produce, the chronic stress associated with poverty or racism, all these profoundly impact a person's ability to manage a demanding chronic illness like heart failure. Addressing these social determinants is becoming increasingly recognized as essential for improving outcomes and reducing disparities.
It's a whole person, whole system challenge. Okay, we've spent a lot of time on the pump and its major failure mode, heart failure. Let's shift focus now to the pipes themselves, the common problems that arise in the vascular system, the arteries and veins, often related to but distinct from heart muscle issues.
Right, and this brings us right back to that fundamental difference between arteries and veins. Quick recap. Arteries carry blood away from the heart, they're high-pressure muscular tubes. Problems here usually involve blockages or narrowing, like atherosclerosis, that reduce blood flow out to the tissues, causing ischemia.
And veins.
Veins carry blood back to the heart. They're lower pressure, thinner walled, rely on valves. Problems here often involve valve failure leading to blood pooling, venous insufficiency, or clots forming within the veins, DVT.
And the underlying process for a lot of arterial problems is atherosclerosis, that plaque buildup.
Yes, atherosclerosis is the villain in many vascular stories. It's that gradual process where cholesterol, inflammatory cells, calcium, and fibrous tissue build up inside the artery walls, forming plaques. These plaques narrow the lumen, the open channel, restricting blood flow, and make the arteries stiff and less compliant. This is the root cause of coronary artery disease in the heart and also peripheral artery disease, or PAD, when it affects arteries outside the heart and brain, usually in the legs.
So peripheral artery disease, PAD, is basically atherosclerosis clogging up the leg arteries.
That's the most common cause, yes. The narrowing reduces blood flow down to the leg muscles and tissues. And the classic symptom this produces, a real hallmark of PAD, is intermittent claudication.
Explain that again.
Intermittent claudication is pain, aching, cramping, or fatigue, specifically in the muscles of the leg, often the calves, but sometimes the thigh or buttock that comes on predictably with a certain amount of exercise, like walking a block or two, and is relieved relatively quickly by rest.
Why does exercise bring it on?
Because exercising muscles demand much more oxygenated blood. If the arteries supplying those muscles are narrowed by plaque, they simply can't deliver enough flow to meet that increased demand. The muscles become ischemic, and that lack of oxygen causes the pain. Rest reduces the demand, flow catches up, and the pain goes away.
Makes perfect sense. Supply can't meet demand during activity. What other signs point towards PAD? Things you'd see or feel?
You look for signs of poor arterial perfusion in the affected leg or foot. Pulses below the level of the blockage, like the pedal pulses on the top of the foot or behind the ankle, might be weak, diminished, or completely absent. The skin might look pale, especially when the leg is elevated, or sometimes dusky or reddish, dependent rubor, when it's hanging down. The skin often feels cool to the touch compared to the other leg.
What about hair and nails?
Chronic lack of blood flow affects skin appendages too. You often see loss of hair on the lower leg, foot, and toes. Toenails can become thick, brittle, and slow-growing because they aren't getting enough nutrients.
And in severe cases, ulcers can form.
Yes, severe PAD can lead to tissue breakdown and the formation of arterial ulcers. These are typically very painful. They often occur on the toes, between the toes, or on pressure points like the heel or ankle malleoli. They tend to look small, deep, like they've been punched out, with well-defined edges and often a pale or necrotic plaque base because the blood supply needed for healing just isn't there.
Okay, so PAD, lack of flow out, causing pain with exercise, cool, pale skin, weak pulses, and potentially painful ulcers on the toes feet. Now, flip side, chronic venous insufficiency, CVI. That's a problem getting blood back up, right?
Exactly. CVI is caused by damage to the valves inside the veins, usually in the legs. These valves become incompetent. They don't close properly, allowing blood to leak backward and pool in the lower legs, especially when standing or sitting for long periods. This pooling is called venous stasis.
And that pooling causes very different symptoms than PAD.
Very different. The venous stasis leads to chronically high pressure inside the veins of the lower leg, known as venous hypertension. This high pressure makes the capillaries leaky, forcing fluid and even red blood cells out into the surrounding tissues.
Leading to
Significant edema, or swelling, typically in the ankles and lower calves, that often worsens throughout the day and improves with leg elevation. You also see characteristic skin changes. As red blood cells break down in the tissues, the iron pigment, hemosiderin, gets deposited, causing a brownish or brawny discoloration of the skin, particularly around the ankles, called hemosiderin staining.
So not pale and cool like PAD, but swollen and maybe brownish.
Right. And the skin often feels warm, not cool, due to the pooled blood. People with CVI might describe their legs as feeling heavy, aching, or tired, especially at the end of the day. Itching can also be a problem due to the skin changes.
And ulcers can happen here too, but they're different.
Yes, CVI can lead to venous stasis ulcers. These typically occur in the gaiter area, around the inner or outer ankle. Unlike arterial ulcers, they tend to be less painful, though they can still hurt. Larger, more superficial, with irregular borders. They often have a weeping, wet appearance with granulation tissue at the base, because there's blood flow to the area, but the high venous pressure and edema impair healing.
Important distinctions, and management for CVI often involves
Helping that venous return. Elevating the legs whenever possible is key. And compression therapy using specialized compression stockings or rafts is a mainstay. The external pressure helps support the veins, prevent backward flow, reduce edema, and improve calf muscle pump function.
Makes sense. Now, related to venous problems, but more acute, is deep vein thrombosis, DVT, a blood clot in a deep vein.
Yes, a DVT is a clot, or thrombus, that forms within one of the deep veins, usually in the calf or thigh, sometimes the pelvis or arm. This can obstruct blood flow back towards the heart.
What increases the risk of getting a DVT? The sources mention Virchow's triad.
Virchow's triad summarizes the three main factors that predispose someone to clot formation. First is venous stasis, blood pooling or flowing sluggishly. Think prolonged immobility like long flights, bed rest after surgery, paralysis. Second is endothelial injury damage to the inner lining of the vein wall. This can happen from trauma, surgery, especially orthopedic surgery on hips or knees, or irritation from high-D catheters. Third is hypercoagulability, an increased tendency for the blood itself to clot. This can be inherited, genetic clotting disorders, or acquired due to cancer, pregnancy, certain medications like oral contraceptives, dehydration, or inflammatory conditions.
So stasis injury or sticky blood, what are the classic signs if a DVT forms?
The most common signs are localized to the affected limb, usually one leg. Unilateral swelling, one leg bigger than the other, pain or tenderness, especially in the calf, warmth over the affected area, and sometimes redness or discoloration of the skin.
What about that Homan's sign they mentioned, pain on flexing the foot?
Yeah, the sources mention Homan's sign, calf pain with forced dorsiflexion of the foot, but it's really important to emphasize that it's considered unreliable and potentially unsafe. Many people with DVTs have a negative Homan's sign, and some without DVT have a positive one. Plus, there's a theoretical concern, though probably small, that the maneuver could dislodge the clot. So clinical practice relies much more on assessing for the unilateral swelling, pain, warmth, and redness, along with risk factors.
Good clarification. Let's briefly touch on aneurysms again, weak spots in vessel walls.
Exactly. An aneurysm is a localized bulge or dilation in the wall of blood vessel, most commonly an artery, caused by weakness in the vessel wall layers. The aorta, especially the abdominal aorta, is a common site. The danger is that the weakened wall can rupture under pressure, leading to catastrophic internal hemorrhage, which is often fatal. And hypertension, high blood pressure, we talked about its effect on the heart's afterload. How does it impact the vessels directly? Chronic hypertension is like sandpaper on the inside of your arteries. That constant high pressure damages the delicate inner lining, the endothelium, making it more prone to injury and inflammation. This accelerates the process of atherosclerosis plaque buildup. It also makes the artery stiffer and less elastic over time, arteriosclerosis. This vessel damage increases the risk not only of heart attack and heart failure, but also stroke due to damaged brain arteries, kidney failure, damaged kidney arteries, aneurysm formation, and PAD-E. Controlling blood pressure is absolutely fundamental for protecting the entire vascular network.
Okay, so we know the signs and symptoms. How are these different vascular problems specifically diagnosed beyond the physical exam?
Specific tests help pinpoint the issue. For peripheral artery disease, PAD, the ankle brachial index, ABI, is a key non-invasive test. You measure the systolic blood pressure at the ankle and compare it to the systolic pressure in the arm. Normally, ankle pressure is the same or slightly higher than arm pressure, ABI 1.0. In PAD, the blockage reduces flow, so ankle pressure drops. An ABI below 0.9 is diagnostic of PAD, and the lower the ABI, generally the more severe the disease.
Simple comparison, powerful information. What else?
Duplex ultrasound is extremely useful for vascular issues. It combines standard ultrasound imaging to visualize the blood vessels with Doppler ultrasound to measure the speed and direction of blood flow within them. It can directly identify blockages or narrowing in arteries, PAD, assess valve function and reflex in veins, CVI, locate blood clots, DVT, and measure the size of aneurysms. It's non-invasive and provides real-time information.
And that D-dimer blood test.
D-dimer is a protein fragment produced when a blood clot dissolves. A D-dimer test measures the level of these fragments in the blood. An elevated D-dimer suggests that clotting and clot breakdown are occurring somewhere in the body. It's quite sensitive, meaning if you don't have a clot, the D-dimer is likely to be normal. However, it's not very specific. Many other things besides DVT or PE can raise D-dimer levels, like surgery, trauma, infection, cancer, pregnancy. So a negative D-dimer test is helpful in ruling out DVT-PE in low-risk patients. But a positive test doesn't confirm a clot. It just means further investigation, like ultrasound, is needed.
Okay, different tools for different vascular questions. What about medications specifically targeting these vascular conditions?
They aim at different problems. To prevent clots in arteries, where platelets play a big role in initiating clots on ruptured plaque, we use antiplatelet drugs. Aspirin is the classic example. Clopidogrel, Plavix, is another common one, often used if aspirin isn't tolerated or in combination after procedures like stenting. These make platelets less sticky.
And for clots in veins, like DVT?
For venous clots, where the clotting cascade involving clotting factors is more central, we use anticoagulants, or blood thinners. These interfere with the clotting factors. Warfarin, Coumadin, is an older oral anticoagulant requiring regular blood monitoring, INR. Newer options are the direct oral anticoagulants, or DOACs, like rivaroxaban Xarelto, apixaban aliquis, dabigatran pradaxa, which don't require routine monitoring but still carry bleeding risks. Anticoagulants are used to treat existing DVT-SPEs and also to prevent clots in high-risk situations like atrial fibrillation or after certain surgeries.
What about statins? They're for cholesterol, right?
Primarily, yes, statins lower LDL, bad cholesterol, which is a major component of atherosclerotic plaque. But they do more than just lower numbers. They also help stabilize existing plaque, making it less likely to rupture and cause a heart attack or stroke, and they have anti-inflammatory effects on the vessel wall. So they are crucial for managing atherosclerosis, the underlying cause of much PAD and CAD.
And antihypertensives, obviously, for managing the pressure.
Absolutely. Controlling blood pressure with antihypertensive medications protects the vessel walls from ongoing damage, reducing the risk of atherosclerosis progression, stroke, aneurysm, and kidney disease.
Managing these conditions really sounds like it needs a team effort and strong patient involvement.
Definitely. Collaborative care is often essential. Depending on the problem, the team might include a vascular surgeon for procedures like bypass surgery, stenting, or aneurysm repair, an interventional radiologist, a primary care provider, a cardiologist, a wound care specialist for managing those difficult arterial or venous ulcers, a physical therapist, especially for supervised exercise therapy and PAD, and a dietitian for managing cholesterol, diabetes, weight, and sodium intake.
And what are some key interventions patients themselves are involved in?
Patient engagement is critical. For CVI, adherence to compression therapy and leg elevation is paramount. For PAD, participating in a structured, supervised walking program is one of the most effective treatments for improving claudication symptoms. Walking to the point of pain, resting, then walking again helps the body develop collateral circulation, eventually small bypass vessels. And for almost all vascular conditions, smoking cessation is non-negotiable.
That keeps coming up.
Because it's probably the single most important modifiable risk factor for both arterial and venous disease. Smoking damages vessel linings, promotes clotting, constricts vessels, and worsens atherosclerosis. Quitting provides huge benefits.
Okay, and finally, what about when vascular problems become true emergencies? We need to recognize those red flags.
Two stand out prominently in the sources. First is the link between DVT and pulmonary embolism, PE. If a piece of that clot in the deep leg vein breaks off, travels through the bloodstream back to the heart, and gets pumped into the pulmonary artery, it can lodge in the lungs.
Blocking blood flow to the lungs.
Exactly. A PE obstructs blood flow through the lungs, impairing gas exchange and putting immense strain on the right side of the heart. Signs are usually sudden onset. Sharp chest pain, often worse with deep breaths, shortness of breath, rapid heart rate, tachycardia, sometimes coughing up blood, anxiety, dizziness, or fainting. A large PE can be fatal very quickly. It's a medical emergency.
Okay, sudden chest pain and shortness of breath, especially with a history or risk of DVT, think PE. What's the other major vascular emergency?
Aneurysm rupture, especially an aortic aneurysm rupture. If that weakened bulge in the aorta tears open, it causes massive internal bleeding. The classic symptom is sudden, severe, often tearing or ripping pain, frequently in the abdomen, back, or chest, depending on the location, accompanied by signs of shock, a rapid drop in blood pressure, hypertension, fast heart rate, clammy skin, altered mental status. Survival depends on getting to immediate surgery.
Both sound terrifying and need immediate action.
Absolutely. For both suspected PE and aneurysm rupture, the priorities are immediate call for emergency medical help, administering oxygen if available, ensuring IV access can be established quickly for fluids and medications, and rapid transport to a hospital capable of handling these critical events. Time is critical.
We've covered a tremendous amount: the pump, the pipes, the pressures, the common failures, how we assess them, how we treat them. Let's try to pull it all together now, thinking about prevention and why understanding all this detail is actually empowering for the listener. The sources had consolidated lists for health promotion.
Yes, and importantly, the lifestyle factors that benefit the heart also benefit the vessels, and vice versa. It's all one system. So the key evidence-based recommendations kept reappearing. Smoking cessation, we can't say it enough, is probably number one. Adopting a heart-healthy diet pattern like the DASH diet or Mediterranean style, rich in fruits, vegetables, whole grains, fish, nuts, lean proteins, low in saturated trans fats, cholesterol, sodium, and added sugars. Regular aerobic exercise is crucial. Aiming for at least 150 minutes of moderate intensity activity per week strengthens the heart, helps control weight, blood pressure, and cholesterol, improves insulin sensitivity, and boosts circulation. Effectively managing existing conditions like hypertension, high cholesterol, and diabetes through lifestyle and medication adherence is non-negotiable.
And screening.
Routine screening allows for early detection. Knowing your numbers, blood pressure, cholesterol levels, lipid panel, blood sugar, glucose or A1C, and getting them checked regularly as recommended allows you and your provider to intervene before major damage occurs. And finally, finding healthy ways to manage stress is important, as chronic stress contributes to inflammation and other factors that harm cardiovascular health.
All interconnected pieces protecting the whole network. And let's revisit health equity one last time, consolidating how those non-medical factors create disparities across both cardiac and vascular health.
It's crucial because these factors significantly impact who develops disease, how well it's managed, and what the outcomes are. Barriers like lack of health insurance or underinsurance limit access to preventative care, specialists, and necessary medications due to cost. Transportation challenges can make getting to appointments difficult. Health literacy affects understanding of conditions and adherence to treatment plans. Language barriers can impede effective communication with providers.
And the broader social determinants.
Social determinants of health, things like income inequality, educational attainment, the neighborhood you live in, affecting access to healthy food or safe exercise spaces, exposure to environmental toxins, and the pervasive impact of systemic racism all create profound inequities in cardiovascular risk and outcomes. Culturally confident care, using appropriate assessment tools and tailoring education, like dietary advice respecting cultural norms, is essential but often lacking. Medication affordability remains a huge hurdle for managing these chronic conditions effectively. Addressing these systemic issues is vital to achieving true health equity in cardiovascular care.
It really paints a picture of health being about much more than just biology. So bringing this all back home for the listener, why should they care about the details, the preload, afterload nuances, the difference between PUTZ and CVI, the RAAS system? How does knowing this stuff actually help? Expert speaker. Because understanding this incredibly intricate network is fundamentally understanding how your body operates, how it stays alive, how it functions optimally day to day. It moves beyond just vague notions of heart health. It empowers you to be a truly informed and active participant in managing your own health. How so? Expert speaker. Knowing about perfusion, for instance, clarifies why controlling blood pressure, cholesterol, and blood sugar is so critical because they all directly impact that essential delivery of oxygen nutrients to every cell. Understanding concepts like preload and afterload gives you insight into why certain lifestyle changes, like lowering salt intake to reduce preload, or specific medications, like ACE inhibitors to reduce afterload, are prescribed for conditions like heart failure. It makes the why behind the recommendations clear. And recognizing symptoms. Expert speaker, yes. Being able to differentiate the potential meaning behind leg pain. Is it claudication suggesting an artery problem, PAD, or aching and swelling suggesting a vein problem, CVI, or acute calf pain suggesting a clot, DVT. Allows you to interpret what your body might be telling you and seek appropriate medical attention sooner rather than later. It demystifies symptoms and empowers you to communicate more effectively with healthcare providers. So it connects those daily choices and potential symptoms directly back to the underlying mechanics of the system. It makes healthcare less of a black box.
Exactly. Ultimately, all these conditions we've discussed, a weakened pump in HF, blocked arteries in PA, leaky valves in CVI, clots in DVT, high pressure in HTN, or just different ways that essential perfusion gets compromised. Understanding the specific mechanism of failure in each case helps explain why different treatments are used and why prevention is so important.
It truly is an amazing, complex, and deeply interconnected system. You see how a problem in one area, like stiff arteries driving up afterload,
Directly strains the heart muscle,
or how a weak heart reducing flow to the kidneys.
triggers hormonal systems, like RAAS, that then increase volume and pressure, making the heart's job even harder.
It's a constant balancing act. A breakdown in one part really does cascade through the whole system.
Appreciating that interdependence, that interconnectedness, is really key to understanding overall health.
So let's leave you, our listener, with this final thought to mull over. How does this deeper understanding of the continuous vital flow of blood throughout your body, the pump pushing, the pipes delivering and returning, the pressures driving it all, the ways it can falter, how does this knowledge empower you to make choices today and tomorrow that actively protect and sustain that life-giving flow for the long haul?